Yeah? Okay, great. All right, everybody, good afternoon. Why don't we get our lunch plenary started so that we can listen to these fine gentlemen talk about head injuries and go and enjoy the beautiful weather that Saskatoon has to offer this afternoon. Our session today is Navigating the Gray Zone, Understanding and Managing Patients with Mild Head Injury in the Emergency Department. Our guest speakers today are Drs. Eddy Lang and Eric Clark. I am not Catherine Varner. She got Rona'd in the last day or two, so she's at home and we're hopefully wishing her a speedy recovery. As always, we'll start with our land acknowledgement. We can pay respect to the First Nations, Inuit, and Métis peoples and traditional territories on which we live, work, and play. Gathering here today, paying respect on Treaty 6 territories and the homeland of Métis, paying our respects to First Nations and the ancestors of this place, reaffirm our relationship with one another. This meeting place is home to many Indigenous peoples across the Turtle Island, and we're grateful to have the opportunity to be here with you all today. By way of disclosures, my name is Suneel Upadhye. I'm an associate professor of emergency medicine at McMaster University. There's some other stuff I do that's not related to this talk right now. In a shameless plug, I am the bass player for Docs at Rock, and we hope to see everybody here this evening. The venue is fantastic, so if you come, I hope you'll have a good time. Oh, sorry? Okay, it's something about wristbands. What is it? Oh yeah, pick up your wristbands. I guess they're still on sale at the main desk if you want. Should be fun. Our other speakers, Dr. Eddy Lang is the soon-to-be not chair, I guess, anymore, of the University of Calgary and Alberta Health Services Calgary Zone, full professor, department head at the Cumming School for Emergency Medicine at the University of Calgary. Well-known educator, award-winning educator, senior editor for CJAM that we all read and enjoy, leadership in knowledge translation, evidence-based medicine operations, and he's a guidelines methodologist for the Canadian Task Force on Preventive Health. Eric Clark, also well-known to the audience here, he's the current CAEP CPD director, works in the Ottawa Hospital since 2000, director of the Faculty Development, deputy head of the Department of Emergency Medicine at the University of Ottawa, exam board member as well for many years, and then serves as their chair. So we'll have lots of great knowledge to hear from Eric and Eddy. By way of disclosures, financial support, this session is being supported by Abbott Laboratories. Otherwise, the program has no in-kind support. There were no declared conflicts of interest for myself or the speakers. They can cover that in their slides as well. And evidently, there's an honorarium for us. I just found that out yesterday. That's great. Otherwise, strategies for mitigating bias, the Scientific Planning Committee, they've independently conceived this topic. Drs. Jen Bryan, Eric Clark, Brittany Ellis, Catherine Patoka, and James Stempian. None of them had any conflicts to declare with regards to today's topic as well. There are accreditation requirements through the College of Family Physicians and Royal College of Physicians of Canada, all of which have been provided. And the presentation slide content meets all the standards for the presenters today. So that's who we are, again. Oh, did I miss something? Yes, I did. Oh. Right. The speakers do have Mentimeter audience response queries, so if you're not familiar with this, you can log in there and check the QR code, and that's the code for the meeting, and then respond when the appropriate questions come up. I guess, all right, I'll leave that up for a moment. People want to clearly take a photo of this. Yeah? Not yet? Once, twice, thrice, and gone. Okay, fair enough. And otherwise, the objectives of the session are these 5 things. We're gonna have a discussion. Catherine and I did a symposium on some of these topics last year in Toronto, and this is being furthered today with Eddy and Eric. Talk about the new Falls decision rule that Kirsten DeWitt and her group published on last year. Defining head injury as it relates to mild traumatic brain injury, and emerging approaches to diagnostic labeling of concussion in the ER setting. New paradigms for how to manage head injury patients that are anticoagulated, either with DOACs or warfarin. Adapting all of these strategies to the realities of rural emergency medicine practice, and then new evidence on biomarkers that may help with prognostication of these patients. So with that, I will turn it to Eric.
Thank you, sir. Okay. Thank you, Suneel, and thanks everyone for coming, and thanks for the free food for drawing everyone here. My name's Eric. I'm taking over for Catherine's first few slides here, so we're going to wing through that pretty quickly. The lineup today is a little bit of a potpourri of minor head injury topics, and I think the overall theme might be that less is more, which is always a good thing if we can decrease resource utilization. There we go. Okay. So we're going to start with a case. It's a case that every single one of us has seen many times in a small emerge and in a big emerge. There we go. So this is an elderly lady. She's 75. She lives in assisted living. She had a fall from standing, and she's come in to see you. She looks pretty well. She feels okay and examines at her baseline. And I think all of us have seen this patient multiple times. And all of us acknowledge that this is probably a high resource type of patient, meaning they often get imaged, they often stay in the department for a long time, they often get transferred for imaging and stay in that department for a long time. And while the Canadian CT head rule, I think, is the one near and dear to our hearts and works incredibly well, we have some patients that don't necessarily have their CT ruled out with that Canadian CT head rule, and we need some other guidelines or help to maybe decrease some of the overuse. So, as we mentioned, Dr. Kirsten DeWitt may be in the room somewhere. It's always nice to present someone else's research. I really hope I don't screw it up. Was aiming to prospectively develop a clinical decision rule that can exclude clinically significant minor head injury in elderly patients who've fallen. Okay, and so she's done that. At least developed the rule that then needs to be prospectively developed, and it's called the Falls Rule. This had about 4,300 patients. Over a quarter of them were anticoagulated. Over a third of them were on antiplatelet medications who presented. Is that right? We've got a funky... There we go. So who's this rule for? It's patients over 65. They fall from standing, their bed, a chair, a toilet seat, whatever it is. Again, very, very common. And so they enrolled, as I said, 4,300 patients. And they were able to go through 17 different items to try and find a rule that would be simple and helpful. And so this is the Falls decision rule that they've come up with. Okay. The patient did not hit their head. The patient remembers the events. No neurologic abnormalities on the exam. They're at their baseline. And the clinical frailty score is less than 5. Okay. Reminder, this is the clinical frailty score. This is ubiquitous. It's been I think, developed almost 20 years ago and then updated and validated in numerous ways. Most of us probably don't use this a ton on a day-to-day basis, but it is there and easy to find. And how did the rule do? Well, it did incredibly well. In fact, it would have reduced CT use in this group of patients by almost 20%. Okay, so that's significant. Sensitivity, negative likelihood ratio of 0.07, which is really, really strong. Now, the specificity wasn't fantastic. So they decided to go and try and simplify it a little bit. And they developed what's called the focused Falls decision rule. And really only two things on it. So the patient did not hit their head when they fell, and there's no neurologic abnormalities. The patient's at their baseline. The rule states they don't need a CT head. Oh, no, sorry, folks. So how did this rule do? Slightly less well in terms of sensitivity, but it's still extremely well at 95%. Okay, so a very easy 2-point little rule that you can use on these patients who have fallen, didn't hit their head and are at the baseline. They don't need neuroimaging. They can be sent home. All right, so that's the focused Falls rule. So, sorry about that, folks. So this was the first time a prospective derivation of this kind of type of rule was made. The next step, of course, would be to prospectively go and roll that out and show that it performs at such a high level in a safe manner. So back to our patient. She's older, she fell, she didn't hit her head, she's well and at her baseline. Her frailty score would probably put her around a 4, so she can actually go home without any neuroimaging, and we have a safe way to do that for her. Okay? So thanks to Kirsten for doing that, and we're obviously awaiting the prospective validation of that little rule. And I'll hand that over to Eddy, I think.
Testing? Oh, great. Thank you, Eric, and a real pleasure to be here. I'm really grateful to the Scientific Planning Committee for inviting me to Saskatoon, and a huge congratulations to the organizing committee and the CAEP office for putting on what has been a phenomenal meeting so far. So in my part, we're going to talk about 3 things. As you can tell from the title of my section, we are going to talk about diagnostic labeling in head injury, significant head injury that would meet criteria for one of those 2 labels. We're also going to talk about the very common dilemma we face around neuroimaging, and then finally looking for post-concussive syndromes. So let's start with a very Canadian case. You have a 17-year-old female who was at a figure skating practice, who, after a jump, landed, and at the completion of the jump, lost her footing and hit the back of her head. She's previously healthy student, has not had previous concussions, and is only known for situational anxiety. What happened at the skating rink is that upon landing on the ice, she experienced a brief loss of consciousness of a few seconds. There was some skin avulsion and bleeding, and I'll tell you about her exam in a little bit. There was one vomiting episode, and she was advised by her coach, her trainer. Everybody was a little bit concerned by what they saw, and they said, you better go to the emergency department. You've probably had a concussion, and you may need a CAT scan. So on arrival in the emergency department, there is some nausea, but she gets therapy for that and it improves, and she reports a moderate headache. There is also a fairly encouraging exam. Her GCS is 15. There was no history of any retrograde amnesia, and she is also not demonstrating any evidence of basilar skull fracture. There's no hemotympanum. There's no battle sign. So I think you know where I might be going with this case. I have a Mentimeter question for you. So does anybody have any questions? Is the case pretty clear? Would you scan or would you not scan this patient? Or there is a third category, which is perfectly fine if you wish. You're just going to say, not sure, but I'll check the Canadian CT head rule to see. So great, we're seeing about 40, 50 responses. I'll just wait a few more seconds. And this is wonderful. You know, I mean, I think we should be really proud of Dr. Steele and the Ottawa group for leading this research. We instituted the Canadian CT head rule in our electronic health record, but before we did so, we did a cluster randomized implementation trial, and we showed that for the physicians who were randomized to receive clinical decision support using the Canadian CT head rule, there was a significant reduction in CT head utilization. So based on these responses, this is great. We're seeing that the CT head rule, or the equivalent, is going to be used to avoid an unnecessary CT scan in this young woman, and that's wonderful. So just to remind you, this is I mean, as close to, I think, an ironclad clinical decision rule we have in emergency care. It's been validated multiple times and demonstrates really, really high, 97% or higher sensitivity in systematic reviews and meta-analyses, meaning that if it's negative, if the findings are consistent with no need for neuroimaging, you're going to be right almost all the time. So let's go over the criteria. I think it's also important. This is, of course, the MD Calc interface that you might be familiar with this, where you can see a very neat interactive version of the Canadian CT head rule. Always pay attention to the eligibility criteria. This is not for what we call minimal head injury. There has to be evidence of neurological dysfunction so that it qualifies as a minor traumatic brain injury. There has to have been something, whether it be the amnesia or some other feature to suggest neurological dysfunction. And remember as well that there's an age limitation. This is not for kids. This is not for people on blood thinners. Thanks to Dr. DeWitt for doing the follow-up work on that. And once you have an eligible patient, you can then go to the radio dial items, put in the information as it pertains to this particular patient, and it spits out an answer for you. And as I said, we have embedded this in our EPIC system, and we don't have data on how well it's being used, but I think it is probably being referred to in the decision making. So this is great. I mean, just imagine how many thousands of CTs we've prevented by applying this rule in clinical practice. And I have no idea, but I imagine there's also probably some brain malignancies that we've prevented as well by avoiding unnecessary CTs. Not surprisingly, CT head decision-making and application of the Canadian CT head rule almost always rises to the top of the choosing wisely list because it's so well supported by evidence. And we can, of course, appreciate this patient has been sent to the emergency department with the intention of make sure you don't have a bleed in your brain, make sure nothing bad has happened. There's going to be some patient expectation, family expectations to manage, but just to remind you, there are some great resources as it relates to choosing wisely in the CT head rule question that you can provide to the patients and their families to help them come together on a decision on whether they really want to have a CT or not if they're insisting on it. Oh, is it this? Okay, great. So here's the thing. Do you want to tell this patient that, so she'll ask you, what happened to me? The parents want to know, what happened to me? Was it a concussion? Was it a mild traumatic brain injury? Or they're actually the same thing, but what you actually tell them is it's a concussion. So clearly that is the winning choice here. And you're absolutely right. They are the same thing. They're synonymous. They both associate with transient neurological dysfunction. Of course, you could think that concussion is a much more well-known term, has been around for probably a lot longer, and a mild traumatic brain injury may be more of a technical term. But I guess it's something that I've been thinking about lately. We know that concussion can lead to sequelae, and there is, of course, a lot of information on the internet about concussion, the dangers of concussion. There's always been periods of time, depending on the news cycle, where concussion reaches very high levels of awareness in the population. And I think we just need to be cautious about using the term, or maybe preferentially using another term that may have a better impact on prognosis, although I don't have evidence for that. But my personal tendency, especially after preparing for this talk, is that I will be trying to stay away from the term concussion because it carries so much baggage. Good news is that we have wonderful, very well-developed clinical practice guidelines on concussion. This is the Canadian website, pedsconcussion.com. I can gladly report that the board of CAEP has endorsed these excellent guidelines. They're pediatric-oriented, but you'll find on the website really amazing resources for people who have sustained a concussion, especially the children who have sustained a concussion. And of course, as you may be aware, there's been quite a pendulum swing in the management of concussion. We are definitely moving away from the, stop school, limit activity, close yourself in a dark room, to a much more permissive activity as tolerated and a more active recovery from concussion in children, and I think that's true for adults as well. So pedsconcussion.com is a great resource for you. So the final topic I'm going to cover is around the topic of post-concussive syndrome. We've all seen these patients. They're often really debilitated. Would you screen for post-concussive syndrome risk factors? So we'll let that go for a little bit longer. I don't know whether these risk factors are at your fingertips or whether you would look them up, but would you try to give the patient a sense of whether they might run into trouble and hence maybe define their post-head injury, their post-TBI, mild traumatic brain injury trajectory based on these risk factors? So we see a bit of a split score here. We've got maybe 3/4 of the people saying that they would or that they wouldn't. So let me present some evidence to you that may help refine that choice. We're lucky, the American College of Emergency Physicians has just last year published a guideline on this. They do a fairly thorough evidence review. There's some room for improvement, but I think it's overall pretty solid. And they say that in adult ED patient diagnosed with mild traumatic brain injury and concussion, their question was, are there decision tools or factors that identify patients requiring follow-up care for post-concussive syndrome or to identify patients with delayed sequelae after discharge? So they looked at all the literature. There was tons of literature, but they actually only ended up with the lowest category of recommendation. So had there been randomized controlled trials to say that screening and referral made a difference and improved outcomes, that would have been a level A, but they didn't have those. If they had really strong observational studies with strong effects that doing so made a difference, they would have said that, but they could only come up with a level C recommendation. And here we're talking about items like previous head injury, the etiology being related to assault, whether there was pre-injury psychological history. All those things might make you more inclined to say, you know what, you might be at risk for a post-concussive syndrome, and maybe I should refer you to a sports medicine clinic or a head injury clinic, as opposed to simply following them up with their family doctor. So, although we have a lot of information on this, and I'll show you that on the next slide, there is some question as to whether we should clearly be doing so, at least in all patients. So this is quite an area of active research. This is a systematic review that just came out. I believe there was over 20, it's an overview of reviews. So there have already been 25 systematic reviews containing 312 articles that have identified 35 different prognostic factors that can identify a patient who can go on to post-concussive syndrome. So that's a lot of variables, a lot of possibilities, and a lot of research. But unfortunately, the conclusions are a little wanting. They say at the end of the day that no single prognostic factor demonstrated convincing and conclusive results. However, age, sex, and multiple concussions showed an affirmatory association, so young women being the risk factor for a post-concussive syndrome. And despite all the research that's been done, they highlighted that still more work is needed. And they also, if you're interested, they did come up with an extensive analysis. You can see it in this figure, both describing predisposing factors, precipitating factors, and perpetuating factors, all of which have been associated with post-concussive syndrome. So you also got to wonder, if there's so many different items, is any of them, or is any reasonable combination of them helpful in making this prediction? So closing thoughts from my end. Remember, you're seeing a lot of head injuries, but not all of them will meet criteria for a minor traumatic brain injury. And there may be, because of some of the history of concussion as a diagnostic term and some of the media hype around it, MTBI may have advantages in terms of discussing the diagnosis with the patient. The CT head rule, we're lucky, remains an ironclad decision tool for deciding who needs a CT. And I hope I've made you aware of numerous great resources. And personally, I don't feel there's a very strong need to predict post-concussive syndrome at the time of the ED visit. And if there's reasonable follow-up and good attachment to primary care, maybe a wait-and-see approach may be the best to do. So that's it for me. I want to thank Eric for taking the bulk of Dr. Varner's slides, no, all of Dr. Varner's slides, actually. And the next section is back to him.
Okay. Okay, so we're going to, last little run of slides here. Again, starting with a case. Again, super common. She's 72. She's active, healthy, trips and falls and strikes her head. She feels pretty well and examines well, and there's no external signs of significant injury. But she's on rivaroxaban for her atrial fibrillation, and she has been told that if she hits her head, she's to go straight to the closest emergency room because bad things are going to happen, and she needs a CAT scan. Now, I usually work at the Ottawa Hospital. It's a big tertiary care center. We have 24/7 imaging and almost 24/7 access even to neuroradiologists and things. But sometimes I go to a place called Kemptville, which is about 45, 50 minutes outside of town. And Kemptville has 3 nurses when they're fully staffed and no x-ray after 11 or 10, no blood work, and of course no CT scan. So I saw this woman out at Kemptville. So what am I going to do with her? Let's start with this. Who would send this woman an hour into the big city to wait in the terrible Ottawa hospital to be seen and then have a CAT scan? She wasn't so keen on it. She was on rivaroxaban and had taken it that day. So we got a good split happening here. So interesting. I like it. So she asked me a couple really, really good questions. Do I really need a CAT scan? Is there really an increased risk with this blood thinner medication? She asked me, isn't there a blood test that you can do at this point that can predict all of this? Like, come on, it's 2024. And then lastly, she asked me, well, what the heck is a brain surgeon going to do? I'm standing here talking to you. I feel fine. Like, I'm not letting someone drill a hole in my head, right? All very good questions. Asking, why do I need to go to the terrible Ottawa hospital? And I'm going to start or lead with the answers. And they might be a little bit sort of, surprising, or maybe I'm being a little glib. But no, DOACs probably don't change your risk of having an intracranial hemorrhage. Isn't there a blood test you can do? Probably soon. There might be actually one that we can use to help predict who needs a CAT scan. And what is a neurosurgeon going to do for me if I'm standing here talking with you and feel fine? Absolutely nothing, right? So she was right on all these things. It's a little grayer, a little less clear or simple than that. So, we just talked about the Canadian CT head rule. I think we all know patients who are on Coumadin and DOACs and clopidogrel, et cetera, are excluded from the rule. And this has resulted that expert recommendations, protocols, policies, and standard of care now is that most patients who are anticoagulated with something get a CT when they've hit their head. Despite the fact that there actually wasn't tremendous evidence that the DOACs in particular resulted in an increased chance of having a significant intracranial hemorrhage. So this study was actually presented last year. Another amazing, great Canadian study looking at intracranial hemorrhage after head injury among older patients on anticoagulation seen in the emergency department. So this is a great big cohort study from, I think, CAEP and CTAS data that they pulled together. And they looked at the risk of intracranial hemorrhage after going to the ED. They also looked at mortality and neurosurgical intervention rates among 3 groups of patients. Patients who are on nothing, patients who are on a DOAC, and patients who are on Coumadin, okay? So huge group of patients, right? over 77,000. The majority were not on anything, but there was 9,200 patients on a DOAC. There's 3,700 still on Coumadin. So a pretty significant numbers. The overall incidence of a significant intracranial hemorrhage was just under 6%. It was pretty clear that warfarin results in an increased chance of having an intracranial hemorrhage in someone that falls and hits their head. Okay. The mortality rate was no different between the three groups. Okay. Patients on Coumadin probably needed a little more neurosurgical intervention than the other two groups. But the most relevant thing for this is that there was no difference in rates of intracranial hemorrhage between those patients on a DOAC and those patients on nothing. Okay? So this is amazing, right? And this is not the lone thing. There's a whole bunch of other smaller, less impactful studies looking at patients on who've had minor head trauma who are on a DOAC, and all of them show the exact same things. There's also been a whole bunch of studies looking at rates of both spontaneous and traumatic intracranial hemorrhage, the big atrial fibrillation papers, patients placed on DOACs who don't show any difference between the DOAC patients and the patients on nothing. So we're getting a really good signal that those patients who are on DOACs are at no more risk than someone who is on nothing. Okay? So this is, again, fantastic. She was right. She probably wasn't really at an increased risk. There's a study going on right now. I think they need about 4,000 patients, and I think a couple of the authors are actually in the room again. That's being done across Canada and the States, called the CAN-SCAN study, to try and develop a decision tool that will help us pick out the patients who are on a DOAC, who've hit their head, who actually need a CT scan. So looking forward to that, as I think that will, again, further allow us to get away from scanning everybody that bumps their head but feels perfectly fine. What about the blood test? Okay, so I am not an expert in biomarkers. However, there are a whole bunch of different biomarkers, which are products of breakdown from different parts of the neurons, that are being studied to see how they can be used to help with a whole variety of things. Okay, prognosticating in minor head trauma or in severe head trauma, for that matter. Prognosticating on concussed patients. And for this case, prognosticating about who really needs a CT scan, who has an intracranial hemorrhage, and who doesn't need a CT scan. Okay? They are looking at blood samples, saliva samples, CSF samples. Those, of course, would be on patients who have severe brain injury and things like that. There are a couple biomarkers that are being used already in the States and in Europe that are used to identify those patients who don't have an intracranial hemorrhage and, of course, then don't need a CT scan. There is still a lot of work to be done to clarify a bunch of things, like the kinetics of when these biomarkers are released and when they drop back down to normal limits, what happens in renal failure, what happens with different sized patients, the timing. It's almost like troponin, if you think of it that way, that still needs to be really fully clarified to decide this particular biomarker, if it's drawn within this number of hours, how accurate is that going to be to help exclude whether someone really needs a CT head or not. There are a couple that are, if they're done within a few hours of head injury, are showing sensitivities closing in on 100%. Okay? Now, those are all smaller studies with small groups of patients and things. It's not ready for prime time yet, but you can see a time where that might actually be a helpful thing to have, especially if I'm out at Kemptville. Lots of my colleagues go out there to work as well. We could do a blood test. We could say, nope, you don't have an intracranial hemorrhage. You don't need a CT. Away you go. We're done. So someday. And then the last little bit I included here was just her question about what's the neurosurgeon going to do for me. If you have worked at a tertiary care center for a while now, you have seen the interest from neurosurgeons in small subdurals and intracranial hemorrhages do this, right? They're sending everybody home. Sometimes they might repeat a CT, but often they say, yeah, no, send them home. We'll see them in a month, see them in 6 weeks. So it's kind of interesting to see that change in practice, but then to understand how they're deciding which patients need what, okay? Who do they want to come and see? Who do they want transferred? Who do they want to admit and watch closely? And sometimes there's a method to the madness, and sometimes it just seems to be they're making up some sort of rule as they go. Now, that's not to say that if you identify someone with an intracranial hemorrhage, most of us would still at least discuss it with neurosurgeons. But I can tell you now, where I work, I often will see the tiny little subdural and go, they're not going to do anything for that. The person's going to sit here for 6 hours, get a CT head repeated, and then they're going to go home with some Tylenol. So I brought up this little study. Well, it wasn't that little, actually. But this is actually happening in the States, right, who much more driven by both finances, perhaps, and medical legal concerns. But the American Association of Surgeons of Trauma developed what are called the BIG guidelines, the brain injury guidelines. They collected a whole bunch of patients, developed a decision rule, and then this is a prospective validation of that the BIG guidelines or the BIG classification, okay? And I'll show you what Big 1 and Big 2 and Big 3 is in just a second. But if you are classified with your head injury as Big 1, essentially nothing happens and no one does anything, and they're suggesting you should just go home. If you are Big 2, you might get a little worse clinically, but again, they never do anything about it, and it doesn't really change much in terms of your morbidity, mortality. So this is a big, busy slide, but these are the classification systems. And you can see in Big 1, okay, so this includes patients who have small subdurals, small epidurals, small traumatic subarachnoids, no intraventricular hemorrhage, but they're not getting hospitalized in the States. They're not getting transferred to a neurosurgical site. They're not even getting repeat CTs done, okay? So this woman standing in front of me who feels fine and doesn't even have a headache and just wants to go home, she's right. Neurosurgeons have zero interest in her, which is great. She doesn't need to meet them. But if this is happening in the States, you know that Canada's probably even sending more of these kinds of patients home, okay? So just a little tidbit to put on the side. This is how neurosurgeons are starting to decide what to do with their people. Okay. So back to those 3 good questions she asked me. Do the DOACs, am I really at risk? Well, probably not, okay? I think most of us would still, clinical standards would dictate that if someone's fallen and hit their head with any significance and they're on a DOAC, a lot of people are still going to CT though, okay? Especially if you're at a tertiary care center where you have easy access. If you're at Kempville, where there's no CT scan, that's some shared decision making. You have a discussion about the real risks, the real benefits, and what's going to happen when you drive into the big city. Is there a blood test that we can do? Not right now. You can see a future where that might actually be a helpful thing for us, but there's significant work that needs to be done to clarify the specific questions and then how you use that assay. And what's the neurosurgeon going to do for me? If I'm standing here talking to you, then I probably don't need to meet a neurosurgeon, and they are not interested in me and my brain injury. Okay? So I think that's it. We got some time for some questions, probably.
Yep, yes we do. Thanks, Eddy and Eric, for a great presentation, and in the spirit of being good Emerge Docs, finishing way early. So we do have plenty of time for questions. If you want to ask questions, I hope there's questions. There's lots of stimulating, new, interesting material here. If you want to step up to one of the podiums, introduce yourself. In the meantime, I'll say thanks to Eddy and Eric for giving a great plenary. Thanks to the planning committee and all the work they do in the background to make these types of sessions happen. So, very good. Oh, other housekeeping issues. Please be sure to fill out your evaluations on the app online, and then you can subsequently claim your credits from whichever college you happen to belong to. So, questions? Go ahead.
Hi, it's Peter Toth. Thanks for the presentation. Is there a role for stopping anticoagulation after mild traumatic brain injury in people who would be sort of moderate risk? I'm just curious, those people that you might not be scanning, whether there's a role and they have the chronic prophylactic anticoagulation.
Which mic is turned on? This one? Okay. So I guess I'd say, again, that's a little bit of a discussion with the patient. Why are you on the anticoagulant, right? How is it safe for you to stop it for a couple days? I've actually suggested that to people, and sometimes, they don't know me, they don't trust me. The cardiologist who they love has told them to always stay on this medication. So it's, right? I don't think it's necessarily a bad idea, but if the DOAC isn't leading to increased intracranial hemorrhage to start with, then there's probably no point in stopping it.
Peter, there is one article that Kirat Grewal did in CMAJ, following up from the one that was presented here, looking at delayed rates of intracerebral hemorrhage with people who are anticoagulated. And again, the only offending agent to be worried about was warfarin. Anybody who was on a DOAC was not at increased risk of delayed ICH. Other questions? Yep, go ahead.
John Rizos, if you're 2 hours away and the patient is on warfarin and they have a minimal injury, they have someone to observe them, there's no neurological injury, there may be a little bit of a frontal bruise, how do you use shared decision-making in that crusty 80-year-old who certainly doesn't want to come to Toronto, not Kingston, and probably not even Ottawa?
No. So Toronto's worse than Ottawa is what you're telling me?
I'm saying there are probably, well, it depends, where are there more politicians?
All right. So, obviously Coumadin still carries that greater risk, right? We see less and less patients on Coumadin, but, those of us who practiced when that was all we had, we're used to seeing patients deteriorate with the big hematomas while on the Coumadin. So, I tell patients, this isn't jail. I'm not the warden. I can give you my advice, and then you can listen or not. I think someone on Coumadin who has some significance, my advice would be to go into the big city and get your CAT scan done. And if they refuse, maybe we watch them in our department for 6 or 8 hours, or maybe they decide to go home and their wife rolls her eyes and drives her stubborn husband home.
The earlier literature suggested that scanning them early was not as effective as scanning them in 24 hours. So, first of all, your comment on that, and if you believe that, which when I initially did, I did, and I'd have people either be reassessed. Now, of course, with the guidelines being what they are, and we no longer have to give our firstborn for a CAT scan, they're very easy to get. And yet, earlier on, I'd either have them follow up with a reliable family physician or come back to the eMERGE. Very small sample size, but in that sample size, in 24 to 48 hours, people were okay. Again, very small sample size. But I do get the sense that the delayed bleeds may be more of a concern with warfarin than the ones we're going to pick up in the emergency department.
Yeah, so you're right, the delayed bleeds with warfarin are more of a concern. The reality is so most patients aren't getting their scan done within 2 hours of their head injury. By the time they get there and then they wait and then, or they get transferred, it's many hours after the actual injury. And there is, for the most part, no real role for a scheduled repeat in someone who's had a normal CT to start with. Okay, I think follow-up or at least monitoring is obviously, for an anticoagulated patient, makes good common sense, but there's no need to repeat a CT scan or necessarily even have them come back for a physician assessment if you trust who you're sending them home with.
Now, where does clopidogrel fit in the spectrum?
The short answer, I'm not sure. It's going to be less than Coumadin. It's probably less than the DOACs.
I don't know if Kirat's here in the audience, and maybe she could answer it.
Yeah. Where's the smart people?
Kirat, right here? No? No.
Thank you.
Chase her down. We'll introduce you.
Okay.
You can ask her. Any other questions? No? All right, well then let's wrap up this lunch plenary. Thanks again, Eric and Eddy, for an informative session, and the planning committee, and go enjoy your afternoon. And we'll see you all at the Coors Event Center at 9 o'clock. Thanks.